Welcome, everyone. It's like the room is starting to fill up. I'm going to kick off in about 45 seconds, and we'll get moving forward on this. Okay, our numbers have stabilized. Good afternoon. My name is Dan Andrus. I am the director of the Substance Use Disorder Treatment Project at the Foundation for Healthy Communities. And on behalf of Growth Partners, the Bureau of Drug and Alcohol Services, and the Foundation, I welcome you to this Hospital Systems Addictions Care Community of Practice event, Redefining Success in Patient Care. This learning event is sponsored by New Hampshire's Bureau of Drug and Alcohol Services and is coordinated by the Hospital Association's Foundation for Healthy Communities and the New Hampshire Technical Assistance Center under Growth Partners. I'd like to thank the volunteer planning committee members, and especially for Dr. Carrie Nolte for their time today and commitment to the care of people with substance use disorder. I think we're ready for the next slide. We are recording today's meeting, so we ask that everyone mute your microphone when you are not speaking. If you are having internet issues, try turning off your video camera or join by phone. If you are having trouble hearing, expand the audio icon and open audio settings. Here you can select a different speaker from the menu or adjust the volume. Our meeting today will feature our keynote presenter, Carrie Nolte, who will both present key information and lead us through two small group discussions using case studies to explore the use of harm reduction principles in healthcare settings. This community of practice is one way the Bureau of Drug and Alcohol Services and the Foundation for Healthy Communities is supporting hospital-based administrators, healthcare providers, and other practitioners implement systemic and effective approaches that address the substance use disorder needs of patients and enhance patient and hospital outcomes. Toward this end, each meeting builds on the previous one to support continuous learning and the exchange of ideas and resources that support this journey we are on. Spearheading this journey is Lindy Keller, Resources and Development Administrator for the Bureau of Drug and Alcohol Services, who will provide a brief recap of where we have been and how it relates to today's meeting. Lindy?
Good afternoon, everybody, and we can go to the next slide. Okay. I think we've gotten that one too. There we go. I wanted everybody to see all the busy work we've done thus far in this group as we've met. As I think many of you have been a part of this before, but just a quick update that this group is really about trying to help whole systems of hospitals to be able to better help folks who have substance use disorders. And we began this whole process by brainstorming, what do you think would make things better? And the graphics on the right show you all the ideas that we came up with and then organized them and began to realize that there were really three key things that needed to be attended to. And one of them was the overall culture of the hospital system in general, but also of each office or each unit within the hospital with regard to how they view and respond to people with substance use disorders. The second one was thinking about developing a care team that would have some specialization who could be supportive of moving this system, these changes forward, and also kind of be some in the background, more or less experts who could help to support those who are beginning to make some of the changes. And then the third piece that it was really important to address was hospital champions, and in particular, folks from any one of the various parts of the hospital or different staff levels in the hospital, but also especially focusing on some of the higher level administrators to make sure that they would be backing the kinds of changes that need to happen. This is a major systems change, and we know it takes a lot. But informing all of those pieces that we discovered was really important was the actual experiences of the patients who come into the presence of the healthcare specialists who have addiction and what it's like for them. So we spent some time looking at that. Today, what we're going to do is we're going to revisit some experiences of a particular patient. And but I also wanted to say, I think it's also important for us to pay attention to the real life experience of the staff or volunteers who are working in the hospital. So we're going to meld those two together, hear from a particular patient, and then also think about what it's like for the staff there, what their experience is like, and what needs to change in order to move toward better care for folks with addiction, particularly focusing on harm reduction as a way of redefining what it means to be successful in a particular interchange with a person with addiction. So having said that, I'm turning it back over to Dan so we can get into the meat of all this.
Okay, I have a brief introduction of Carrie Nolte, our presenter today. Carrie is an assistant professor of nursing at the University of New Hampshire. She holds a PhD in nursing, I believe, from Northeastern University, if I'm correct, Carrie. And she is a faculty member and a scholar of the highest order. She has had multiple publications across a range of professional journals on issues related to patient treatment, and is someone who is continually involved in some groundbreaking research in the fields surrounding substance use disorder and patient care generally, particularly for populations which are often underserved by our healthcare system. Carrie is a past board chair of the New Hampshire Harm Reduction Coalition and has been instrumental in forming that organization to become the agency it is today, providing statewide services. She's also a passionate care provider who really models for all of us what effective patient care looks like. And I'm so glad that she is in the teaching profession where she can transmit some of that. Carrie, it's a pleasure to welcome you today. And I hope I haven't missed anything, but your curriculum vitae is long, and we're just delighted to have you with us today for this community practice.
Academia makes me keep it long. It's not my personal preference, but yeah, I think, I continue to work clinically, and as a family nurse practitioner, and that's really, where I found myself in moving towards this path of academia. In general, my job was to, see patient after patient and increase billing and all of that. And in a primary care practice. And I think, I always wanted to develop new programs and change things and do new things. And so that's where academia has been a really good fit for me. It's like a choose your own adventure of how you want to be productive. So I'm really looking forward to this. This group, I kind of pitched a new strategy in doing this. I think that in part of my work, I do quite a few interviews with folks, either hospitalized, not hospitalized, people who use drugs most often. And I think that their words, their experiences, their values are so important, and is just such an opportunity. And I wanted to kind of share just a little piece of that. I will give the caveat that I know that substance use in court, is a wide range of uses. Most of my work is focused on people who inject drugs and opioids. So if you hear that focus, it's not intentional. It's just my world and kind of what I know best. So I would encourage folks to connect more with other substances, things you're not hearing, things that might be specific to your region. That's so important, and not just focus on kind of what it is that I know or think. So I think we'll move to is it the next slide now?
I think it's your slides, Carrie.
Okay, I'll,
That's the context.
yeah, I think I'm gonna just do that right here. So if, Monty, you wanna just go to that, just looking at timing, go to the next slide, I'm sorry. Go to that, it's so clear on Zoom. So, you know, within this, we're gonna move quickly into small group discussion for a little bit. I ended up, there's sort of two versions of a case study. And what I want you to, what I'm hopeful that we can do together is discuss some of the elements of care that are there, whether that's sort of consistent for what would happen in the hospital system you're connected to or hospital systems. And then to also broaden that. So like I said, all of, you know, my work is focused primarily on people who inject drugs. All of the interviews that this case study came from is from a person who's hospitalized in New Hampshire for septic arthritis for related to drug injection. So I think too, you know, so I've highlighted a few different opportunities for where we could change care and, you know, learn from each other in these sessions, you know, talk about what different systems do, who does it better, you know, just I'm hoping that this can be a good starting point for a great conversation for all of you. And now, Mana, do you want to move us to the groups?
Sure. Okay, we'll be breaking out into breakout rooms shortly, and you will see the case study in that group. So just one moment.
Mana, I have a question for you and you.
Okay, it looks like we're all back. I think, Carrie, it's you, take it away.
Looks like we are all back except our speaker.
Now, Carrie's here.
I'm here.
Oh, there you are. Okay.
Just tech things. Okay. Okay, there we go. Well, I hope that the sessions were good. I got to lurk for a couple minutes in each of them. And I think that I want to focus on or make sure that it's very apparent to everyone. Like, I'd love for you to interrupt me in this to discuss this. We have a small group, which is a huge asset. And so let's take this opportunity to have more of a conversation throughout this. I make the same joke every time. That's probably not funny to many of you who are seeing me before, but I don't have any disclosures. But if you know big business that wants to fund me and give me disclosures, to fund harm reduction work, I'm happy to be connected and take those. So as we look at the objectives, exploring principles that can be applied and then gain insights into what successful patient care is. And I know, I know that Dan was taking some great notes that can be passed on. I don't know if you guys can, well, this is my coworker, Allie. She only stands in front of me when I'm speaking, and sometimes she speaks also. So a little bit of background on the case study interviews that were there. So this is a project that was conducted in 2017 and 18. Is not yet published. It's on my perpetual to-do list. I will happily follow up with it because I think these narratives can be really helpful to all of you working in making culture change. But I'm also happy to present these results if you think that it would be helpful in doing that sooner than that being available. So background on what people who inject drugs experience from literature is that, people perceive discrimination. As you know, they're much more likely to leave against medical advice. And I know that there is a new term for that I always mess up, but it is patient-initiated discharge or something to that effect. And then often they rarely feel safe, welcomed, or without stigma, and avoid care due to fear of loss of control. And then we all know that there is an incidence of more overdose after discharge, often related to opioid tolerance, coping strategies, etc. And so some of the risks are decreased engagement, decreased honest disclosure based on the stigmatization and discrimination, and decreased connection with harm reduction services. And so some of the benefits that have been known is that certain providers do provide higher quality care, positive affect, show sympathy and concern, and that really increases folks' engagement in healthcare and also preventing future hospitalization. And we want to establish positive rapport because folks will honestly disclose their substance use and other key parts that are important for their care plan, and then are more likely to adopt provider recommendations and seek timely care. And so this was a study. It looks like this visual, they're like spitting popcorn into each other's mouths. That's what I think, but whatever, I've kept it. This is a sample of 17 in-depth interviews with 17 individuals who were experiencing a complication of injecting. The interviews were done while they were inpatient in 4 New Hampshire hospitals, and there was a survey and a semi-structured interview. And I'm sorry, it was 2018 to 19 that it was conducted. And thank you to those hospitals that participated. In general, I won't be disclosing what hospitals they were, although all of them have been really supportive of this work. And so some of the summaries, and we looked at, negative interactions and positive interactions. And as a nurse and as a nurse educator, I've really tried to focus on promoting those positive interactions because they're very basic. So actually listening and having a game plan for patients. So as much as we talk about stigma and supportive care, what was really clear in the interviews was that people weren't asking or recommending providers do anything more than really what is the basic expectation in care. But often I think the lack of comfort with treating folks with substance use led to people not really communicating even what the plan was, approaching with an idea that they wouldn't understand or that they didn't have capacity to be included in that plan. And so the positive interactions were very basic. People who actually listened, built them up, talked about how, you know, they were so glad that they came in, that was really important, that they recognized they needed it, advocated for them, gave them a game plan of what was going to happen, not just in the minute, but over the next week or two, and treated me like a human. So this isn't a huge change. It's just really applying these principles and also calling out principles, the principles of care engagement when they're not there. And one of the things that isn't apparent, but is very apparent in the case study that you were provided, but was very apparent through the interviews, was this negative component of having less freedom from jail. Many people with substance use have experienced incarceration. And in general, you know, it was really that one person could really sway their care in a negative direction. So one staff person who suspected them of use in the hospital, suddenly their care would flip to, they weren't allowed visitors, their room was searched. They had a 24/7, they had someone watch them pee. That was a big focus. Someone watches me pee. And it wasn't even whether or not those, like that search resulted in anything, or there was any behavior or anything that was found in that, but rather just that one person's suspicion completely changed their care trajectory. Because once we put those measures into place in the inpatient setting, they're rarely, if ever, removed. So it's not that they have a 24/7 sitter and we're like, you know what, this person is doing good. I think it's that we can safely remove that. And so those are just kind of the overall context of those interviews. And I'll pause here if anyone has questions or comments on any of these pieces. So one thing that I think, and I'm just going to really move this into a set of kind of recommendations or opportunities that I think can be helpful. And then we'll go back to those case studies and talk about, you know, some of the changes that may be considered in approaching care differently. And so, you know, I think with approaching systems change, you know, one thing that I always engage with is really that, you know, this has been a process for me as well. And so we should kind of utilize a harm reduction approach in approaching other people. Meeting people where they're at is not just for people who use drugs, but also care providers who are trying to make those changes. And so, you know, I had done clinical rotation in needle exchange as an undergraduate in Boston quite a few years ago. And then when I did training as a family nurse practitioner, I walked into practice and would often say what my preceptors had said, which is, we don't treat addiction here. We don't treat addiction here. And that was like 2008. So like 10 years ago. And that was really very common and typical. And, you know, we thought that what we were doing was appropriate at the time because we thought addiction is very complex. It needs to be treated in specialty, all of these things. But what we were doing is causing harm by saying, you know, this isn't part of your medical care. And it's so complicated that we need a specialist to do this, which would have been fine if those specialists were available, but they weren't. So when we said that, you know, you have to go to specialty, it then like led to, you know, no care for that addiction. And so within that, now in this work, so I want to recognize that, like, I've learned and really integrated some of those early things from needle exchange into the care I provide. And so within that, though, it can be very off-putting to clients. So recently in a Healthcare for the Homeless van visit, you know, I had a patient who had a very serious infection that absolutely needed to be seen in the emergency room. and probably admitted for IV antibiotics. And she was in very active withdrawal from opioids. And her biggest concern was that she had used cottons, which filter the drugs that have some remaining drug. And so she had diluted the cottons because she didn't have any opiates remaining, and had done a injection of like a wash, a rinse hit, so that there were some opiates. And so she knew the system. She was so knowledgeable about the system of care that she said, I can't go, I did a rinse hit and they're not gonna give me Suboxone. And this is someone that was like very actively in withdrawal. And so that was the main concern for her, was like, I can't even address this because I'm in withdrawal. I need to find opiate because I know that they're not gonna address my withdrawal. And so that led to coordination of care with the emergency room, and really ensuring that there was a provider that would address that and trying to provide that reassurance to encourage that person. But all of this is extra work and extra knowledge and extra things, and all the things that I love learning and trying to find better ways. But I think part of what was really interesting to me in the situation is how knowledgeable these clients are about what we do and what to expect and what we have in the setting, and how they will or won't be treated. And that information gets relayed across hundreds of people within their networks. So as we make changes, it's really important to share those with people who use drugs, and also to say, hey, things are changing, and like pass this along. This is how this new program is going to work. So I'm sure that many of you have seen similar around harm reduction, that we look at this as just safety measures that protect ourselves, that everything that we do is inherently risky in one way or another, has risks and benefits. And so all of these are examples of very common harm reduction strategies. So the principles of harm reduction are really that we want to use practical strategies to reduce negative consequences. It's also a social justice movement that respects the rights of people who use drugs, and accepts that drug use is part of our world and works to minimize harm rather than ignore it or condemn it. So drug use is complex. Any substance use, alcohol, everyone has a reason. No one self-selects to struggle with addiction, but part of it is addressing the causes and looking further into the why for use, as opposed to like a chemical addiction. And then harm reduction also understands substance use is complex, with a continuum of behaviors, some ways of using safer than others. And this really should be a non-judgmental approach to empower drug users to share info and support each other. And it can be done in so many different ways. And I think that Tanya's patient engagement work is so important in this, and to really, if a facility, if an institution, whatever, wants to really have systems change, it has to incorporate people who use drugs or people who have had these experiences to be effective. So we all look at a continuum of substance use, and to recognize that not all substance use is the same. And so very often the stereotype is that especially opiate use is always chaotic. And for some people, it's not. Some people do use fentanyl, heroin, occasionally, socially, regularly. So talking about that and recognizing kind of where somebody is. But within that, really thinking that chaotic, heavy, and regular use is often connected to seeking refuge from suffering and losses. And so, stepping back from the piece of like chemical addiction, but really looking back at like where use kind of comes from. And so another thing that's really important is, you know, any positive change. So any step towards in the right direction is a positive one. So one of the risks that we have is, and we've all heard the stories, is, you know, the person who was, you know, was using was drinking excessively, you know, a couple handles a week, and they decided to go cold turkey, stop, and they just jumped right from excess to abstinence. They hit rock bottom, you know, that like really motivated them. And that those narratives are simple, they're easy to identify, but they're so damaging, because that is not the typical. For every one story of those, I can tell you, you know, hundreds of other stories that that's not the case. So if folks are going from excess to moderation, you know, acknowledging that there's a few steps down, a few steps back up, and that's normal. And that's part of what we expect in substance use. And so looking at how we approach people. So, you know, often, you know, we find, and as a nurse, I rag on nurses mostly, but we find different strategies. And especially we have this piece where folks think, I know the right thing to do for you. The use of scare tactics to me falls under that. So, you know, if you keep drinking, you're going to die. If you like, you know, you're so far gone, I'm probably not going to see you again because you're going to be dead. And these are like actual things that nurses have said to patients, and really think that they're effective, these scare tactics. And so all the evidence indicates that that's not super helpful, and really educating, aligning with folks, you know, better than me, let me help you. But really the openness to learning from folks who use drugs or struggling with substances about what that is, what that looks like in their life, and things like that. And so ultimately looking at every interaction can be an opportunity to engage. And as we talk about hospital systems of care, often, especially for injecting infections, we're talking about 6 weeks course of antibiotics. And sometimes not a single person in that care team has truly discussed a chance to change or opportunities or goal setting. So often you have a very, you know, you have a person in for a long period of time who's looking for those opportunities, and they're just not even offered. So how we can do that to support readiness to change, but being open to that might not be abstinence. That readiness to change could be around safer injecting, preventing infections, etc. And so, you know, the first thing I think that we can do a lot more of is opening up the conversation to learn. So, you know, in all of the sessions that we, continuing education sessions, and I think as I kind of came into maybe a bit late, you know, we have all of these trainings, and I know Corey was talking about her and Daisy's training, which is amazing. What I think all of his experience is that so often we're preaching to the choir. You know, it's people who self-select to come to these sessions who already have some capacity. And so especially for new folks or people who haven't engaged in this training, how do we get systems change? And then also, how do we just open up a conversation? So, you know, I tell people all the time, like, I've been trying to learn more about, you know, I've been trying to learn more about injection use. Can you tell me a little bit more about it? Like getting that education from folks, because the approach right then is that engagement and mutual learning. You know, asking people for like feedback on the terms that they use or how they say things or their approach goes so far in just connecting with, I'm trying to learn. I know that as a system, we haven't done this well, and I'm working to do this better. I think the biggest thing, in one really specific intervention that can and should be integrated into all hospital, all healthcare engagements is really around safety planning. And so, this is specific to opioid use, having naloxone, carrying a buddy, or finding a buddy and talking about it. But really thinking about, you've been in the hospital setting, your tolerance is going to be different. Right now your plan is to not use, like you're feeling really good about that plan, and that's awesome. Let's just talk about some of the safety of, like, what would it look like if you did use? How would you stay safe? And, recognizing tolerance is an important part of that. Tolerance for opiates, tolerance for alcohol, whatever it is, but also, not being alone and not using alone. Or if you are, really concerned about using with others, then to have another strategy. And then, some of the strategies are really around all of the basics of take good care of your body, avoid, avoid driving, understand how things are going to affect you, and then switching to a safer method, which I'll talk about more. Another piece in that, offering up that conversation about what if you do, decide to use. Let me just tell you all about the resources. And one really important resource that I think is overtaxed right now, but we see a lot of states adopting a similar program that's state specific, is, Never Use Alone, a hotline that if someone is using alone, they can call, make a safety plan, give their address. If they become unresponsive while using, then they will activate the emergency plan and call 911, call a trusted person that's nearby, etc. And then also integrating trauma-informed care. I know this is a buzzword. I know we've all heard it. Whether when we say it, I think there's very few folks that truly integrate it, that really are mindful of trauma as it relates to substance use. And I think it's just really important that this is not just a thing that facilities do, that providers do. It's an ongoing learning approach. You have to have both organizational practices and clinical policies in screening for trauma, but also being able to address it. And a setting and kind of adage is, don't ask the question you don't want the answer to. So you don't screen for trauma if you don't have the capacity to supportively address it. And you don't have the resources in order to connect that person. So this is just a little, this is a visual from a publication that came out this past year. But what we looked at in this was a study that looked at, had both survey and narrative components, interviews. And so when we looked at injection drug use and the transition to opioid use and the transition to injection, none of the reasons were like the gateway myth of substance use. It wasn't, well, I tried marijuana and then, someone offered me a little cocaine and then boom, I'm using fentanyl 12 times a day. That almost all of those transitions in our interviews were really around trauma, and that trauma also was associated with opioid initiation, also of escalation of use, and then a transition to injection drug use. But that most of the reasons provided in the reasons people moved to injection drug use was very practical based. So a lower cost, increased effect or rush, greater availability, meaning, the pills, OxyContin, things like that were no longer available, but fentanyl was. and then faster relief of their suffering from withdrawal symptoms. Also, talking about and reviewing all MOUD options, medications for opioid use disorder, MAT options, and these extend also to alcohol use that I don't know how well we're doing with integrating medications for alcohol use in inpatient. I know we've spent a lot of time on MAT, but there's more that we can do otherwise. And then also, really focusing on withdrawal symptoms and symptom management. We've seen more protocols come into hospital settings, but in other issues and we have in other admissions, we have order sets. And from my understanding, there's very few facilities that have implemented order sets for opioid withdrawal. That often, individual prescribers will prescribe X, Y, and Z. We do see these kind of sets of opioid withdrawal medications in the outpatient setting in initiation of buprenorphine and things like that. But it's not necessarily become so common that there's consistency in use of some of these. And this is just a short list. There's more of these medications that can help. This is a little inaccurate here. Those numbers came up, but really the overdose prevention, I know it came up in part of the case study, but naloxone should be talked about in the hospital. It should be talked about at discharge. It should be provided. It should be easy. It should be done everywhere, period. Done. If it's not done, it should be. That one's an easy one. And so I've spent a bit of time with the perinatal task force, but one of the things that they focused on has been, and I say this to broaden it from the inpatient or addiction treatment settings, but that, the leading cause of death and really the only cause of death in northern New England has been overdose in the year after childbirth. And so especially for pregnant patients, for people who deliver, making sure that that's integrated, but also what's seen nationally is that timing is not that wild ride of having a newborn at home, that the most common time for an overdose death is like 7 to 11 months postpartum. And so some of the rationale for that, or possible rationale, is that often that's when service connection kind of decreases. So we see people in the first 3 months after delivery. We often programs extend till then, but then things kind of decrease after that. Another component of the case study that I think can really be addressed is talking about safer supplies and safer use. I think often we hear a lot of judgment around, this person just got treated for an infection, now they're back. This is crazy. They just went back out and used, and it's like crazy making to me, because my thoughts are, well, did you talk to them about preventing infection? Did, making sure that people have all of the tools that possible. And I think that hospitals can have an opportunity and a role in this, in providing safe supplies and offering syringe services, in connecting folks to programs and if they have them in their area, and also to connecting to pharmacies. And I've done some work around pharmacy access in New Hampshire, which is not great, but it's okay. Pharmacists are allowed to dispense or sell syringes to anyone over 18 in New Hampshire. Many of the pharmacies choose not to, so advocating for that in your area as well. And then, this is always, I'm sure most of you have seen this before, but just like thinking about the damage that goes along in the skin and the soft tissue, how this really makes people more prone to infections because of the damage surrounding injection site. And so, one syringe, one time, safely disposed of after is really is going to prevent like 95% of all the infections that we see. And then connecting with syringe service programs, which there's some access in the state, but really that syringe access should be a connection point for all of the other ongoing services to connect people with. So another thing that can be for folks that are talking about decreasing use or interested in decreasing use is discussing alternative modes of drug use. So one of the most timely things I think is helpful here is in methamphetamine use or in stimulant use. So we have some medication assisted treatment that's minimally available across the state, but it's not quite as effective as medication assisted treatment for opioid use. So often when people are injecting methamphetamine, they have a very high peak, they have a rush. And so often they may be injecting many times a day. If they transition to smoking it, there's a lesser peak, there's more of a prolonged effect, but that can be a strategy in decreasing use for those who are interested in decreasing their use of methamphetamine, is switching from regular injection to transitioning to smoking as an effort to decrease use. And again, this is very similar. Harm reduction resources, are often use colorful language in order to engage folks. And so, really trying to think about how we provide resources, have something different, disseminate stuff that are from harm reduction organizations, because there's a lot of evidence based and just not having a pretty pamphlet with flowers, but something that's really going to talk to the population. And often harm reduction organizations use like zines or different, handouts that have pictures, things like that. And seeing if we can get all of these very basic things into the educational care plan and facilities. So talking about, why to use tourniquets, that there's fewer needle sticks, less risk for infection, having the bevel up, disinfecting the area before injecting whenever possible, or washing it, and then recognizing different signs of infection. And there's a huge manual that is very comprehensive and focused for drug users that can be used. Also just looking at how all of these things factor in. So these are all the social determinants of health that are associated with health outcomes, but these partnerships that when case management is working with a client who's inpatient, that the greatest predictor of success in recovery is stable housing. And so as much as we can connect them to medications, to treatment providers, to specialists, if we're not connecting with some of these basic needs, the opportunities for success are just statistically limited. And then also, Dartmouth has been doing this and piloting this, so challenging the current policy. So this idea that for people who are admitted for a complication of injecting and they have a PICC line on board, that often we talk about, the PICC line as being owned by the hospital, that they could not, how dare they use my PICC line or our PICC line to inject drugs. But in reality, you don't have to jail folks in the hospital, and many folks do really well and better in outpatient settings. And so we see some people trialing this, but there's still a big lack of comfort around this. And you really have to have a champion to do that. And then finally, looking at ongoing implementation, we're a little behind in harm reduction infrastructure in the state, which is unfortunate, but it also means we get to learn from many other countries and many other states that are really have made amazing changes. So these are just two examples, but harm reduction vending machines, so that they're easily accessed in accessible locations where people in the area use drugs. And then also, supervised drug injection. And that has been very successful in other countries. and is now available in New York, although there may be an injunction to stop that. So I think with all of this, going back to kind of meeting people where they're at and just addressing people with compassion, is, you know, also having compassion, modeling this compassion to care providers as well. And so looking for folks to move from, you know, treating people who use drugs or substances with disbelief, suspicion, apathy, to their integration and kind of more and moving towards integrating all of these principles across. I think we can, you know, talk about questions, and then there's also trainings, resources available on the Harm Reduction Coalition website, and also some of the links in here to some of the resources for providers that the harm reduction education grant that I had been working on at UNH has available to you. So let's chat.
So I'd just like to make a suggestion here, Carrie. Rather than going back into small groups, I think it might be helpful if we just, as the full group, talked about how do we change from what was identified in the first small groups to some of the strategies that you just presented so beautifully. Does that make sense? I'm both looking at the time and also the size of the group we've got here. And I'd just like to suggest that, at least based on my group, there was a good understanding of what things could be better. But the question really is, how do we move from what was identified as sort of treatment as usual to what could be better? And I'm just picking up on what you said, Carrie, early on about meeting staff where they are, not just meeting patients where they are, and how to move folks in the direction of doing this. My one final comment, then I'm going to be quiet, is to say that we titled this training Redefining Success. And I'd like to put people in mind of the picture you had of the staircase, and recognizing that in one interaction with a patient, we're not expecting them to go from the highest risk to no risk. We're expecting them to help them, encourage them to go one step down the staircase toward a lower risk lifestyle. And so how do we do that? That's my question I'm throwing out.
I can share. So talking about harm reduction strategies outside of needle exchange, you know, things that people can do in the immediate. And we've heard from staff, and it started me thinking about the idea, and I love the title of this presentation. I've talked a lot about because we're creating a sense of failure in our healthcare staff, right? When people don't go into long-term recovery, that is usually, and it's a measure of most programs, how many people went 90 days later, how many people stayed in. But there was a hospital that we work with that took some of this to heart, and the social worker had a patient who was not interested in any kind of treatment for his SUD. And so she said, well, what can I help you with? And he needed housing. And so the social worker shifted gears, found him a safe place to live. And when she talked about it, she was just full of success, feeling like she had done something and she hadn't touched or even talked about his SUD. So I think there's such, if we can start framing it, and I know, like, and again, I know I always talk about my own situation, but it's just so relevant to me because I switched as a parent of somebody who uses IV drugs and is currently actively using, and when I switched from the tough love and the, we can't see you if you're high, we can't do this, to more of a harm reduction and getting a lot of support from parent harm reduction groups, it changed my whole feeling of success, right? Because I failed him over and over and over as a parent in my mind, because nothing I did worked. Nothing convinced him to go to treatment. Nothing, I cajoled, I bribed, I threatened, I did everything I could. And now we have a much better relationship. And I just think if that can be transferred to healthcare workers, then maybe the some of their frustration with these patients would be shifted if they just didn't see full abstinence recovery as the only thing that measures success.
Thank you for sharing that, Tanya. And I think too, it's not only are we perpetuating this, get into treatment, that's the outcome, but also not acknowledging that most people have multiple stints in rehab and multiple times. And so it's like a double fit. So you achieve the goal of, getting that person into care and treatment, but then you feel like a failure when then they go back to using, which is totally normal and is exactly what happens. And I think we could get into a whole another conversation about the profit making entity that is addiction treatment, and how that is packaged and sold as 99% successful, which we all know to be blatantly false, and those numbers. So I think too, it's just how to have reasonable expectations based on what's there. And thank you for sharing your experience with your son too.
One of the slides that you had, Carrie, talked about the partnership, said that you are the expert on you, basically. And, instead of saying that we've got the answers, one of the sort of paradigms that has worked well for me is that, I realize that as healthcare providers, we're trying to fix people. And if instead of asking the question of people, what's wrong with you, we say, what happened to you? That's the trauma-informed approach. And once you say what's happened to you and you establish a relationship about some of the root causes and you establish the fact that you're willing to partner, that you're willing to understand, then you can do that step down harm reduction. You're not saying, I'm going to fix you and I know what's best for you, but let's be partners in figuring out what's going to keep you safe.
And I think we would add to that too, what are your goals, right? Because very often the client that I'm working with has very different goals than what I would like for their goals to look like. So, but if we don't know what their goals are, we're constantly pushing for something that isn't where they want to be.
So how do we help our colleagues, other staff members to begin thinking like this? Because those are all of those suggestions are right on target. What's the motivator for the staff to change?
I think, Lindy, this is related, or maybe can kind of bring that to a specific discussion of, one of the things in the case study was around, the hospitalist changing every 3 days and the care being, we got to control your pain. We got to treat your pain. No, we got to get you off of these pain meds, and this constant back and forth that was happening. And I'm curious in that, that one specifically, to build on Lindy's question, how do we fix that? or have there been successes in your systems in addressing that?
Do you mean addressing the continuity of care? Is that?
Yeah, and just the different, like, specifically around pain management or addiction treatment in the hospital setting. So you wouldn't ever have someone that walked in day 3 and said, these are all the wrong antibiotics, we're going to change them all. And then we wouldn't do that every 3 days, but that's been being done to people's pain management or addiction treatment.
Yeah, so aside from the obvious of saying more training, because as you said, people who come to the trainings, if they're not mandatory, and even if they are, you can't force somebody to learn something. But when I think about any time that somebody's in the hospital having that kind of different providers, different thoughts, because that can happen in regular med surg situations as well, is the continuity is the patient and and if the patient has an advocate. So this is where that peer support, I'd love to see peer supporters in every hospital and have that be something. I know there's funding issues and such, but peer support is, so you have somebody who's been there for each turnover of staff to say, wait a minute, this isn't the plan that was in place, and then engaging the patient in the plan and making sure the plan is in the records, however it goes in, but remembering that the patient is a continuous, they're the ones there for every transfer, every change of shifts, and having somebody as their advocate bedside. And peer supporters are doing some amazing work. And I'm not sure why that's not just a standard of care for mental health or substance use, because it's such a powerful opportunity.
Yeah, Tanya, I would add to that we have peer support here, and we've had them for several years now, 24/7. We have a hospital support program, and we have coaches that are coming into our emergency room and seeing our patients in our hospital. And even though I don't feel like they're doing what you described, they're certainly helping the patient to advocate for themselves as well. When they spend time in the room talking to the patient, they are then helping, I feel like they're empowering them to then say what they need. And I think too that our coaches have this sort of behind the scenes thing that they do, because they end up talking to our staff. And I think I always remind the staff, this is such an important person for you to talk to. You're looking at someone who was literally in that hospital bed a couple of years ago, in most cases, for a lot of our coaches. And so it's great for our staff to see that treatment works. People get well. This person could get better. It gives them hope. It gives them something to look forward to, I think. So I think we're making a tiny dent in what we're doing here by having coaches and having peer support folks in the hospital. But I know that there's so much more that we need to be able to do with them.
One of the things about peer support is that people can tell their stories. And I think telling stories is the most powerful way of affecting culture change. And when I started doing MAT in my practice, people said, why do you want to see those patients? Why do you want to see those people? Aren't they frustrating? And then 2-3 years later, 10 people, everybody in my practice was wavered to prescribe. And because they heard the stories. They heard the stories from the people who are in recovery. They heard the stories from me and from other people who were doing the work about how gratifying it was. And we know the substance use touches virtually everybody's family one way or the other. And so that everybody's got a story. And I think we have to make sure that those stories are front and center, and the positive aspects of treatment, what the good things that happen, because people are burnt out and they're frustrated and they're short-staffed. And if you can have them see positive experience, have positive experience with people who are getting into recovery, then it makes a huge difference. And if you show them statistics and show them that people aren't going to die if you do the various things that Carrie outlined in her presentation for harm reduction, I mean, that is the ultimate thing, is keeping people alive.
I just want to recall a story from when we did have some folks be a part of this community of practice who had been in hospitals, and each one of them had both a positive and negative story. And one of the things in this thinking about redefining success, one of the things that I keep recalling is at least two of them said when they had that negative response in the ER, they left. And in both cases, they were there for antibiotic treatment, right? And they just left. When they were approached in some of the ways that Carrie outlined here, they stayed. And I remember this one young woman saying, that was the first time I kept using drugs, but that was the first time that I followed the treatment regimen the way it had been told to me. So what she went to the ER for got treated appropriately. And that's success. So I think that's, she was still using, she's not anymore, but this is a couple of years later. But that's success because you treated what they're there for. And that wasn't happening in the other cases.
Yeah, I think stories are definitely one of the most powerful tools we have, the positive and the negative. It's one of my favorite parts, to help people tell their stories effectively and to be heard. And I also think, there's a reason I always mention my son, and I have full permission from him to talk about him. To talk about my experience with him, not about him in particular, but I think it's also because we just, even amongst ourselves, we don't always, like you said, Peter, we're all touched by it in one way or the other, personally, as well as professionally. And I think being able to not feel shame around it. And I felt a lot of years of shame where I wouldn't talk about, like, let me tuck that part of my life away. Until it helps me in my work. It helps me relate to people that I work with, but with other lived experience. But I think the sharing of stories, and I think the more that we just bring it out into the open, that it's not, that we don't feel shame about it, I guess is what I'm saying.
I think too, Tanya, you bring up, and this is sort of beyond the hospital setting, but one of the things that I often get asked about, and I'm sure many of you, if not all of you on the call, get the same. It's like, oh, my housekeeper's son is struggling with addiction and blah, 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 like these like random occurrences. And I think just promoting what would you do for someone who's struggling with cancer or diabetes or whatever? Like, show up, bring them food, give them hugs, send them love notes, like do all the same things. And I think it's very similar in that way of like destigmatizing that like very often we hear these things shared of someone's struggle and we withdraw because like, oh, it's substance use. And I know no one here does, but I think as much as we can get that messaging out so that other parents aren't struggling and hiding it and, lacking support and experiencing trauma themselves because of it, and how to show up for other people in that.
And I think giving space to the hospital staff to talk about their experiences, because some people have been traumatized by being raised by people who have used drugs, have their own trauma, and really being able to talk about how does that translate into caring for people.
So I'm going to be very mindful of the time here, realizing that there's just about a minute left. So I want to thank Carrie for everything she does for the people in the state of New Hampshire, as well as for her time and efforts on our behalf today. And also to just want to kind of wrap up with a couple of things before you go. it would be really great if it's a small group, but if you could fill out the evaluation, it only takes a couple minutes. Mana just put it in the chat, and you can do that while I'm doing this wrap up. If you are not a member of the COP, we invite you to join. Our next meeting will be scheduled the third Thursday in February. And we will, as you know, this was recorded. It will be saved in the NHTAC website. That's NHTAC, that's New Hampshire Technical Assistance Center.org, which Growth Partners runs for us. All of our recordings from our COPs are there, so you're welcome to peruse those anytime you want. And because this was such a small group, I really invite you to let other folks know about it. And if you felt that the information you received today was helpful, then to encourage people to go there. Any resources, and I'm sure we'll be able to pick some of the ones that Carrie had in her slides out and make them available on that site as well. So share that information with others. If you join the COP, you can also be part of a Google group where folks can share information on the topics we discuss in between meetings or ask for help. New Hampshire Growth Partners provides technical assistance for any of the folks who are engaged in COPs like this. All you have to do is go to their website. They have a very simple way to request technical assistance on anything related to the work that we're doing. And so having said all that, I thank you all for your time. I thank you all for your input. I found it really enjoyable and hope you did. And have a great holiday.
Thank you. You as well.
Happy holidays and stay safe and healthy, everyone.